You see there is a small gap here
Yes.
between the inferior turbinate and middle turbinate.
Yes.
If you make an incision here and just reflect the mucosa, you will see the sphenopalatine artery. This is an important landmark which our ENT colleague used during sphenopalatine ligation for various purposes. Okay, for tumor and everything. Okay.
Yes.
I'm just telling you. Now, so I am going to demonstrate you transtracheal approach first. Okay.
Yes, sir.
So this is the middle turbinate. So I am going to cut it.
Yes.
कैची टर्मिनेट में सीधे टर्मिनेट में दे दो कोई इशू नहीं है नीचे ये रखे टर्मिनेट में ये है if you are doing lateral recess leak then full middle turbinate resection is not required, probably only inferior part required.
Yes.
Because it's not a tumor, it's very small leak, only small defect. Okay.
Yes.
But if you are doing tumor, then the whole middle turbinate is required. So to removing this for doing middle turbinectomy, leave a small stump and just cut it. You can coagulate before that and just pull it down. Okay?
Yes, sir.
It comes down like this. Yesterday I told everything about middle turbinate, what is the ground lamella and what not. I hope everybody must have understood.
Yeah, perfect. Very nicely and elaborately demonstrated yesterday, sir.
So I have done middle turbinectomy. बीच में आएगा This is part of septum which is coming my way, so I am trying to remove it. Okay. So next step is I will try to identify, because I have already done the orbital exposure, so need not to transectomy and all. So I am trying to identify where is the maxillary ostia.
Yes, sir.
So here was the uncinate.
Yes.
This was the infundibulum, and you see there is the opening.
Yes, we can make
So
it.
this is the maxillary ostia.
Yes, sir.
Okay.
Yes.
This is 9 o'clock opening. Are you able to appreciate everybody?
Yeah, we can see it.
डिसेक्टर दीजिए या बालप्रूफ हाँ ये दे दो Dr. Deepak, with whom I have worked at AIMS during my residency, is with me here. You see, this is a maxillary sinus opening, and if you go behind, you see this is the maxillary posterior wall of the maxilla. Okay.
Yes, sir. Very
So
nice.
what you do, just take this. You can strip up this mucosa here.
Yes, sir.
And take it out. हो गया. In orbital surgery, you have to enlarge the opening of the maxillary ostia, because many times when there is edema after surgery, then what happens that there may be chances of maxillary sinusitis. So in every case, we just open after the procedure is over, just increase the opening of the maxillary ostia. Okay.
Yes, sir.
So you have removed the mucosa, not completely but adequately. एक बड़ा वाला डिसेक्टर है यहाँ पर फ्रेयर्स हाँ ये मिल गया. So you see, this is the posterior wall of the maxilla.
Yes, sir. Yes.
Okay.
Yes.
If you go more laterally, you will see the bulge of the infraorbital nerve. Somewhere here. Okay. Are you able to see?
Yes, we can make it.
Huh?
Yes, sir.
So this is basically perpendicular plate of palatine bone. Okay.
Yes.
Now this is the inferior turbinate. Okay.
Yes.
So what I am going to do, I will cut the posterior 1/3 of the inferior turbinate to see more exposure. It not required every time, but to see the landmarks, I will show you. नहीं ठीक ठीक है मैनेज कोई इशू बता देंगे दीपक थैंक यू थैंक फॉर बीइंग विद मी इट गिव्स मी immense pleasure working with you. Okay, so see, I removed some part here.
Posterior 1/3 of the
Posterior 1/3 of the
inferior turbinate.
inferior turbinate. Basically, I want to show you the attachment of the inferior turbinate and the palatine bone. So see, this is the palatine bone.
Yes.
This is the inferior turbinate. Okay.
Yes.
So it is attaching here. You see, this is the crest.
Yes.
This one. Okay.
Yes, we can make it out.
So this is the attachment of the inferior turbinate. Please remember, inferior turbinate is a separate bone. Middle turbinate and superior turbinate are part of ethmoid bone. So that's why it is thick bone. Okay.
Yes.
So this is the conchal crest. This is the ethmoidal crest. So just go behind. You see, there is one artery here.
Yes.
Okay.
Yes.
You see?
Yeah, we can make out that foramen.
Yeah. So this is the orbital process goes in the orbit.
Yes.
This is the sphenoidal process goes toward the sphenoid bone,
Yes.
forming the sphenopalatine foramen.
Yes.
So this is the sphenopalatine artery here. You are able to see the foramen?
Yes, we can make it out.
No problem.
No.
You see, this is the foramen. Okay.
Yes, sir.
Sometimes some people call it crista ethmoidale also.
Okay.
In my slide, it was located as crista ethmoidale. Okay.
Yes.
So this is the posterior wall of the maxilla. This is sphenopalatine foramen. This is the first landmark. And the perpendicular plate of palatine bone. Okay. So now I am cutting it. If you dissect it further, it will take you to the ICA. Okay.
Yes.
Let me show you here. The periosteum covering the ICA. And not for, but just because relevant anatomy, you should know it. You will go to more behind. Okay, this probably this one. Okay. Anyway, we'll see later. No. Future आगे है. ये इधर था. Future was here somewhere. I will do separately. Show everything. So now what I will do? Upcut. ये ले लीजिए upcut. Upcut भी होगा देखो. नहीं है यही दे दो डाउन कर दे दो कोई बात हाँ upcut है नहीं कोई बात नहीं यही दे दीजिए. देखो भैया अगर अपकट हो मिल जाए तो अच्छी मेहरबानी होगी. किसी सेट में अपकट पड़ाओगे कोई भैया? सो आई एम एंगेजिंग. हाँ ना अपकट नहीं है वो ट्रू कट है. मैं इसी का अपकट बना लिया हूँ. तो आई एम एंगेजिंग माई ला भैया ला. हाँ धन्यवाद भगवान भला करे भैया आपका. आपकी लंबी उम्र हो. So I have engaged my upcut in the foramen.
Yes. So there was one question like, do you use microdebrider in your cases for this approach?
Unfortunately, I don't have microdebrider in our OT. We are going to buy it. But yes, if you have, you can use it.
Yes.
But don't think it's essential for doing any procedure. Please remember, the message is that you should be able to operate things with minimum instruments. Everywhere instruments are not available. If you invest more money in the hospital try to have return from you.
Yes.
So this is very important to know the technique. We are in low cost country.
Yeah. So you are opening spinopalatine foramen now.
I'm not only opening, also removing the posterior wall of the maxilla.
Yes.
To show the pterygopalatine fossa.
Yes, which is just.
I have shown in the radiology in the axial section. Behind the posterior wall of the maxilla, there is pterygopalatine fossa. Have you remember?
Yes, perfect. Like we.
So that's what I am showing.
Yes.
Yeah.
And earlier, when you were showing that that you went to the ICA, so which part of ICA you were mentioning? Lateral segment?
No, that was
Parapharyngeal?
The parapharyngeal.
Parapharyngeal.
Behind. Behind it. We have here Mr. Sunil Verma, about whom Dr. Deepak told yesterday. So basically, let me take this opportunity to tell everybody that Mr. Sunil Verma, probably last 25 years, he is in this endoscopy business. And very important credit goes to him. He has established endoscopy in India. He has personally took interest selling endoscope, conducting conferences, workshops, everywhere. And you have seen yesterday the type of question he was asking as if he is a medical person, although he is non-medical man.
Yeah, he is Dr. Sunil Verma, non-medical.
He should begin honorary MCS degree.
Yeah, honorary doctor.
So I have opened the posterior maxillary wall, removed. You see below that there is a periosteum.
Yes, sir.
That's covering the pterygopalatine fossa content.
Yes.
Depending on need, if there is a Denker's procedure you have done, you have go far behind, but usually till V2.
Yes.
Usually bone is very thin. You don't require delivery for this. डाल भैया. Let me tell you another landmark. So this is a periosteum covering the pterygopalatine fossa, okay?
Yes.
So now I will open it.
Any things which you is not clear, you can ask us, we can ask them, or we can clarify it. Right?
Once you open the periosteum,
yes,
you will see some amount of fat and filled with the vessels.
Yes.
Nerve will be after that, behind that. Yes, vascular structures. You can see this is the vessel.
Yes.
Okay? And the vessel is going like this. Now we appreciate spinopalatine artery.
Yeah, we can make out the branch which is.
Can you make out?
Yes, sir.
This is the spinopalatine. Yeah, this is maxillary artery. One branch is spinopalatine artery. Behind that, you will see the pterygopalatine ganglion and all. Okay.
Yes.
So let me show you median nerve first. So yesterday, what we did, we have done the transspinal exposure.
So we can take the mucosa off.
Yeah, we'll take. I'm just showing the landmarks. So I will take off this mucosa. So this is the septum. This was a part of the sphincter turbinate. We'll take it off. If there is any query, please do let me know. The purpose that once you go from here, you should be by here, not the same. You can coagulate, you can clip anything. Intermaxillary artery. कोई करते हैं क्लिप कहाँ मिलेगी भैया, हम लोग गरीब आदमी हैं यार. Okay. So you see, yesterday we opened here.
Yes, sir.
This is the rostrum,
Yes.
and we go lateral till palatospinatal synchondrosis.
Yes.
Okay, at vomerovaginal canal.
Yes.
It was somewhere here. Yesterday we exposed it. This one. Okay.
Yes.
So just lateral to that, there should be the median nerve.
So we can see the foramen there.
Yeah. You'll see everything. So this is the foramen.
Yes.
Okay.
Yes.
So this is the pharyngeal nerve
Yes.
going in the vomerovaginal canal.
Yes.
So where it finishes, there you get the median nerve.
Yes.
Okay.
We can see it.
सिकल नाइफ है. हाँ यही है, तो नीचे ही आपके ये है सिकल नाइफ. ओ हाँ तो भैया. So I am dividing the pharyngeal nerve.
Yes.
You see this canal?
Yes, we can see it.
Huh?
Yes, we can see the canal. So you have just cut the pharyngeal now, right?
Okay. So medial to lateral vomerovaginal canal, you see this is the canal.
Yes.
Okay?
Yes, sir.
You appreciated?
Yeah, we can very much appreciate.
Then VDN and then V2.
Yes. Yeah, so we can see the VDN canal and VDN now coming out of it.
हाँ सेक्शन है सेक्शन है. हाँ लेकिन लास्ट में जाएगा. Okay, this is the VDN nerve.
Yes, sir.
Please remember, the transpsychoid approach is done most of the time, or rather every time with the transspinatal approach also, not in isolation.
So you are cutting the VDN now?
Now
or-
I am cutting the VDN nerve.
Yes. So
One of our ENT delegate is also here, I think.
yeah, we have 3 ENT delegates.
Okay, I thought only one is there.
No, no. Sir.
So we have cut the VDN nerve now.
Yeah. So can you trace the, like there is a question from the professor that can we trace the VDN now till the ICA?
Yeah, we will trace. Okay, now I am trying to see the foramen rotundum.
Yes.
Here is probably the foramen rotundum, you see?
Yes, we can say. So,
This is foramen rotundum.
yeah, so for the delegate, like whole of this transpsychoid approach is around the VDN nerve, which ultimately take you to the ICA.
Yes,
That
yes.
is we protect it, and the rest of the we
Yes.
work around the safe
Yes, yes.
corridors there. So
Yes, so this is median canal opening.
yes, sir.
This is medial pterygoid plate.
Yes.
This medial pterygoid plate forms the lateral part of the cornea. You can see the isolation tube. Okay.
Yes. Yes. Yes.
This is also very important landmark. What I was telling you.
Yeah.
Okay.
Yes, we can see it, sir.
So the medial pterygoid plate forms the lateral wall of the cornea.
Yes.
You see, endoscopy is very addicting.
Yes. So one of the yesterday what we were discussing it. Now just I'm clarifying one point. You can see this is the vomer here, and if we go laterally for sella, this much is okay for us. But if you go laterally, what can happen? These are the structure which are there, which can get damaged. And if you make a flap and if you damage here, that flap will become devascularized. So that is the importance of it. What not to do in this area.
So now what I will do, I will drill the whole of this area. You see, in lateral this is leak.
Yes.
This is sphenoid sinus.
Yes, sir.
Once you go from this side, approach midline, you will see only the pseudomyelin.
Yes.
You will not see from where it is arising. To see the exact opening and do perfect repair, you have to drill this area.
Yes. So most of the fail
Leak
management
because of
was
this,
because of just seeing it and plugging some fat doesn't help. Yeah.
You see, this is the V2.
Yes.
Yeah, this is the sphenoid sinus. Sometimes it gets pneumatized till here. The median and V2 becomes fall apart, and just open this, you will get a pseudomyelin sac. If the tumor if you go much beyond, Dr. Datta.
Yes, I am with you.
Yeah, if you go much lateral, you will see the lateral pterygoid plate. Okay.
Yes, sir.
You go in infratemporal fossa, which you do by Denker's procedure, because beyond this, it's difficult to go from this side.
Yes.
You have to open the interval of the maxilla.
Yes.
See, to go much lateral, which is usually done in cases of JNA.
Yeah.
Okay.
Yes.
So now I will drill this whole bone and show you other things. Okay.
Yes. Even V2 tumors like the extracranial can grow into that infra.
Yes. The tumor itself guide you.
Yeah.
Can you hold?
So ultimately, what sir is trying to tell you, tumor helps you. You don't create a problem by yourself by damaging ICA.
हम ऐसे होल्ड करते हैं. आप ऐसे करते हो? Yeah. इस पकड़ो. नहीं इस पकड़ो. इस हाथ से. हाँ. Just hold like this. ऊपर पकड़ ले. हाँ. Adapt कर लीजिए. It's okay. Can somebody show how Dr. Deepak is holding the scope?
Yeah, we are seeing it. All these movements are into PIP view, and we are watching you.
So this gives a better fixation, I believe.
Yes.
And many times you don't require any endoscope holder.
Yeah.
And you can manipulate accordingly. You see how I'm manipulating to see how is my view.
Yes.
भैया पानी दो. पानी. यहाँ रख दो. यहाँ भैया. ये हमको दे दो. हाँ, Eastern Blood Canal leak. Okay, so the pterygoid process is in front of you. Drill भैया. Drill कहाँ गई? अच्छा, आगे क्या?
So there was a question, what is the structure behind medial pterygoid plate?
Medial pterygoid plate.
Yeah, what is behind medial pterygoid plate?
Sorry. Behind this you will see this pterygoid body. Behind this sphenoid sinus.
Yes.
भाई अभी हम उधर जा नहीं रहे हैं.
ये जो आपका सेक्शन है, what is that?
This is pterygoid plate. This is pterygoid process.
उसके ऊपर वाला. हाँ. That is what is
This
the
is median
question.
canal.
Yeah.
This is V2. This is pterygoid body hole here.
Yes.
And if you go below, you will see the medial pterygoid plate.
Now your section is on which part? Yeah.
The section is on body.
Okay. This is whole body, even
This is whole
posterior.
body. Yeah, this is whole body. I'm going to drill it. If you are using drill, be very careful. Usually I say that 3 things to be in mind.
Yeah, so there is a question, where is the perpendicular plate of palatine? And so we know this medial pterygoid plate.
That part we have, yeah, this is much anterior here. This is perpendicular plate of palatine. This is perpendicular plate of palatine. It attaches with the pterygoid plate. Huh?
Yes.
The upper part of the sphenopalatine that we have already removed. Upper part of the palatine bone we have already removed. Na?
Yes. Yeah, so the basic is the point where we have to go to into this area. There is the ICA. So VDN now protects you that like the last image which I showed with the blue line and the canal, that was the crust of this approach. I mean, you work around this like bone until unless you take this bone off, you cannot reach into the area which is into the middle cranial fossa. So to reach into this area, we have to remove this bone, and it depends, like if it is too pneumatized then it is good, if it is thick then you have to do lot of bone drilling, but you have to work around this VDN now.
So if you are drilling on the VDN canal, you should drill medial and inferior,
Yes.
because if you drill above that, then you may injure the ICA, because you don't know when the ICA will come.
Yeah, so yes, very nice. So the one important point is when now we will be reaching posterior, we will connect with your paraclival,
Okay, the midline.
cavernous and this lateral segment and pitras part of ICA. So you can connect, you can see that what actually we are talking about. So yeah.
Dr. Datta, just see, I am making a part of vomer in my view
Yes, sir.
to make it, see, this is where my drill is.
Yes,
So keep me oriented
Yes.
in the anatomical position.
yes,
This is very important.
yes. And he is drilling on the medial part and the inferior part. If you go superior, there will be a ICA behind. If you go lateral, there will be the ICA behind. Not necessary. We have to remove completely. Transpterygoid means like you have to drill and then you have to go there. We are not operating into the parapharyngeal space. I mean, that's why I said we can remove everything possible thing if the tumor guides us, or I mean, we have to remove the tumor. Yes.
Some flap is coming in the way. I'm
Yeah,
trying
we
to
can remove that flap if at all you want.
Okay, चला गया.
So this should.
I
be-
hope now people will be able, understood where the peltovaginal canal.
Yeah, those are very nicely clarified.
पांडा भैया पांडा लो.
This, yeah.
इसको ऊपर डालो, इसको ऊपर, इसको ऊपर, इसको ऊपर, इसको ऊपर नाक पर. हाँ, हो जाएगा, हो जाएगा, हो जाएगा. There is something known as air current, which I cleared myself. You say, see, this tunnel is not very well pneumatized. Many times VDN nerve is so much pneumatization. You see the VDN nerve from anterior to posterior till the foramen lacerum.
Yeah, so we'll see in some of the cadavers, if at all is there. If it is pneumatized, you can see it is coming medial to ICA and coming out here.
हमको दो. Actually, in real scenario, things are very easy because the tumor guides you. There is bulge. Okay.
Yeah, but even you are making it easy for us.
Sorry.
Your expertise making it easy for us.
No, let me tell you, it's very easy. You plan, you execute the plan.
So you drill between the V2
I am drilling between V2 and VDN.
the VDN.
Yes, and medial and inferior to the VDN to go to the foramen lacerum.
Lateral to the VDN. Inferior and
That is the area. That is the area of pterygoid body.
जाएगा तभी यहाँ पर not to go into the city.
You see now the V2 is exposed more. You see? This
Yes,
is there.
yes.
Huh? V2 is above, that is probably the temporal dura. Is the picture good?
Yeah, very nice. Because it is a fresh cadaver, the
Yes,
anatomy is good, and the color differentiation we can always
No,
we can make.
today we have changed our camera also.
Yes.
Carl people have given good camera now. Image 1S camera.
Yes, yes. अरे medial and inferior. So ऐसे जाके ऐसे चली जाएगी वो पीछे दिखेगा. We are too far from that.
Yeah. I'm externalizing the video now.
Yeah.
It will take me to ICA.
Yes. So the point is like just identifying the area doesn't take you to the ICA. You have to drill a lot of bones. You have to take care of all those things because there will be a lot of dust.
अरे नहीं बता रहे आपको अभी दिखाते हैं आपको बता रहा
Sir, can you just give an external idea about where could be the ICA?
I'm explaining that thing, don't worry. I'm taking out this bone sheet.
Cavernous
I'll take out this part also.
Paraclaval ICA. You can see it here. This claval resist. This ICA from clavus, it will go down there. So it will take a turn, lateral segment and go out. So this is the area where you go inside. नहीं ये एरिया है ना एक पॉइंट पे कैसे बताया था
आपका क्या नाम भैया हैं
एक्सपांड होता नहीं अभी कैसे डॉट हिस्टेज बोल रहे बहुत एरिया में घूम रहा है बट इशू ऐसा है कि दिस इज योर कैरोटिड अभी उस कैरोटिड यू कांट मेक आउट यू हैव टू इमेजिन आइदर यू नो इट और यू डोंट नो इट
Okay. You see, this is the pituitary gland, okay?
Yes, sir.
You see, this is the optic nerve.
Yes.
This depression is LOCR, where my suction, lateral to my suction, okay?
Yes.
There is one, you see, पानी आपके रेजिडेंट नहीं आते क्या अच्छा ही जो रेजिडेंट अरे बार बार आ रहा है यार रास्ते में आ रहा है बार बार कहाँ भैया हो यहीं से ओके फॉर्चुनेट टू बी एन एम्सोनियन 5 year course okay good clinical bhai clinical lo okay so you see this is the pituitary gland
Yep.
this is optic nerve
Yes.
dissect kar diya ye this is the gland This is optic nerve, you see? Okay?
Yes,
This
yes.
is LOCR.
Yes.
You see here some amount of pneumatization. This is pneumatization of intraocular process.
Yes.
This is part of chiasm. Okay?
Yes.
Understood?
Yeah, yeah.
This is tuberculum. This is plenum. Okay?
Yes.
What is MOCR? MOCR is a lateral tubercular crest. Earlier it was thought pneumatization of the middle gland process, but now no more. So this is the tuberculum. MOCR will be somewhere here.
Yes.
Okay? You have to open the MOCR if you want to work in the supracell system,
Yes.
particularly in craniopharyngioma. So what I am going to do, Dr. Datta, अगर आप कहो तो हम सेम टाइम कैमरा से भी दिखा दें,
Yes, 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 sir.
ठीक है? So this is optic,
Yes.
this is tuberculum, and this is plenum. नीचे कर भैया, नीचे नीचे, हाँ. This is plenum. This is plenum, tuberculum, sella.
Yes.
Okay.
Yes.
This is ICA.
Yes.
ऐसे रख लीजिए. Drill.
Yeah, you can over the ICS.
Yeah. So let me tell you first what the ICA is. First, let me demarcate where the ICA is there. Then after I will show you. So this is cavernous ICA. Okay.
Yes.
It is going like this. This is anterior genu. Go behind, and then after make the posterior genu. Come here like this, and you see. This is the median canal.
Yes.
Okay.
Yes. Yes.
No doubt.
Yes.
So this median, if you take posteriorly, it will go to the formal lesson somewhere here.
Yes.
So the ICA is cavernous ICA here.
Yeah. Yeah.
Make posterior turn, posterior genu, come here in the formal lesson, and this will go here. Okay.
Yes, yes.
So somewhere here will be the formal lesson.
Yeah.
So people understood?
Yeah. And from there, ICA will turn to the left.
Yeah, there'll be Petrus ICA.
Yes.
That's what I told you, na. If I go here there is Petrus ICA. ये यहाँ पर.
Yes.
ये देख रहे हैं ना हमारा डिटेक्टर जा रहा है अंदर.
Yes.
Okay.
Again, we are with you now.
This bony region, you can make it flush. Use diamond drill here.
Yeah.
Three things are important. Number one, all the moving drill has two parts. You see, it has a moving part. In this drill, the moving part is very large. Okay. Are you able to see the moving part of the drill?
Just a minute. Just a minute. We are getting back to you. Yes. Yeah.
Are you seeing the moving part?
Yes.
Moving part, okay?
Yes.
So, unfortunately, this drill has very large moving part. It should not be used in endoscopic surgery. It should be very small. And the complete moving part should be under vision to avoid any trauma to the endoscope.
Yes.
Number one. Other thing, the pain reverse technique, what Dr. Sharma, our teacher, has told us. The third thing, when you take out the drill, it should be stopped. Never take out moving drill from the nose. It will damage the not only structure but endoscope also.
Yes. Yes.
So three things are very important. I always ask my resident when I am drilling and they are assisting me.
Yeah, they are very important points.
Dr. Sudhir is there, my resident. He must be recalling.
Yeah, he was here.
Oh, it'll. So I have scrutinized the median. some remnant of median nerve is there.
So we have to always preserve it, right? That it guides.
Yeah,
you.
you preserve it. Guys,
Anyway, you have to preserve it.
It's there. Okay. So let me now come from forward below. Many times we remove the medial wall of the cavernous sinus in case of functional tumor.
Yes.
So at that time we expose the carotid.
Yes.
Pani, bhai, pani. And nowadays we take out the cellular floor, tuberculum, everything in try to take out in a single piece. This is middle class process.
Yes. So yeah, it's slightly lower than the MOCR.
Yes.
Yeah.
So you drill on the ICA when you are planning to
Yes.
carotid?
You drill on the ICA, don't worry. You have to be a little careful, not late but very careful. Use diamond drill, slow, paintbrush technique, make it excel and remove it. Actually, let me tell you, ICA is not bare. ICA is covered with dura also.
Yeah.
Okay, periosteal layer of dura. So don't worry, but still you should not. Some people say that have faith in God but lock your car.
Have faith in God, but
Lock your car.
okay.
So this is the, you see, this is, some people say this is a cobra,
King Cobra, sir.
king cobra, okay? And one this side, other this side. Sitting on a peanut, yeah.
So for the pterygoid approach, we are not supposed to do this. Or
Many times chondrosarcoma become large, it may involve up, it may involve clivus, it's not limited to one area. So depending on the need, where the tumor, you have to make the opening, you have to make the exposure. But always good exposure is good, because if, right now if there is any problem against IC, you can use a clip also.
no, but purely if you are planning for a transpterygoid approach, so then you
If
drill.
you are planning CSF, for CSF it is not required,
Okay.
not at all. But for case of tumor it may require, because most of the time tumor presents in large, tumors are large.
So in pure transpterygoid, you have to restrict your drilling between the VDN and the V2 and
Yes.
medial to the VDN, but not superior or anterior to the VDN.
Yes.
So this is a pterygoid body you are drilling now?
Yes, pterygoid body. Dal do. Most of the time in a real life scenario, the tumor itself makes space. You have seen the radiology, what I have shown in our cases.
Yeah.
So you identify, you don't need much, you don't have much problem. Even navigation is not required.
And how far posteriorly you go while drilling the
You
pterygoid
see
body?
the temporal dura. You see, this is temporal dura, I think.
Okay. Yeah.
This is V2.
Yeah.
This is V2. Here you will see the temporal dura. Because
Yes, sir.
V2
Yeah.
forms the lower part of the cavernous sinus, floor of the cavernous
Yeah,
sinus.
yeah.
You see, this is a triangular process of the bone. This is basically ICA, you see?
Yeah.
This is ICA. This is from a lacerum. This was the median. Okay, which is gone. So it is going to here. Upcut. इसको ले लेता हूँ नीचे से, हाँ. You see the how the IC is communicating now, huh?
Yes, sir.
Okay.
So this is a paraclavial ICA.
हाँ हाँ हाँ. This is cavernous.
Yes, sir.
This is horizontal part. This is anterior genu. This is the posterior genu. It's all covered with dura. You see.
Yeah.
It is a foramen lacerum. Then coming below, this is parapharyngeal part. I told that if you follow this everything is covered with dura. And this small tongue of bone is known as lingula, lingular process.
Okay.
If you cut this, you can mobilize the IC also. If you remove this bone also, you can mobilize it. Okay?
So are there any instances that you've encountered ICA injury?
Earlier, yes, everybody who is सांप के बिल में रोज हाथ पड़ेगा तो एक दिन होगा, कहाँ काटेगा? Yes, I had.
So कितनी बार डसा है सर आपको?
Twice. Funny.
So what were your strategy at that time?
Yes. In my initial phases, I was operating craniopharyngioma, so at that time my knowledge was poor. So that time after the removal of tumor, the IC got avulsed. The patient did not survive. In another case, I was operating a cavernous sinus lesion. It was a schwannoma. We removed the tumor. In the last part, there was IC injury. We packed it, went to angio suite. There was good cross calculation. We put a flow divert. We blocked the ICA, and the patient survived. Now, since then, I am very careful. I spend a lot of time in exposure. And as I told you yesterday, that after bony work, in all extended cases, we take a break. The assistants also take a break, and then after we come back. And believe me, we did not have any problem after that. Yeah, you can do. Sometime you do drill. One important thing is note that you see IC is covered with dura here.
Yes, sir.
So need not to do much worry, but yes, you have to be careful. Be very gentle. Pain brush technique, what Professor Sharma has told, I always, that is, Datta Das, you must be remembering point over here.
Yes, sir.
Pain brush technique.
Yes, sir.
Dr. Datta and Professor Sharma has written a beautiful paper on neurology India.
Yeah,
About
way back in
complication of avoidance.
2015.
I think Datta, you should send soft copy to everybody.
Sir, it was way back in 2015 and still, I mean, like,
Yes.
very nice points that he taught us. And,
Yeah.
it makes
This was basically amalgamation of many works done by many people.
yeah.
How to avoid complication, how to do surgery and all.
Yeah, actually, he very nicely compiled together small points.
Yeah.
And so that you don't have those complications.
You see, there is some amount of fogging. You just take the suction towards the scope. The fogging goes vanishes. This we call it air current. That report, did you appreciate? So I will remove this part of bone.
We can see the remnant of Vidian.
Yes. Not now. It has gone, I think. It was-
What is in front? What is below your drill?
Yeah. हो गया. कट अब कट. नीचे. Yeah. So this is the area of superior abdominal fissure.
Yes, sir.
Superior abdominal fissure is basically continuation of the cavernous sinus. So at the
Yes.
same time, now what I will do that Dr. Datta, should I do the open this tuberculum and plenum
Yeah, yeah. So you want to do right now or?
after break? Okay.
No, no, not break. It's okay. I mean, yeah, yeah, yes. Just please go ahead, sir.
No, people will also do it. They should have time, enough time to.
Yeah, yeah, yeah. Perfect, perfect. Sir, our professor is asking like, have you completed your pterygoid exposure?
Not now, but not completely, but almost. Huh?
Yes. So you want to connect so that the
Yes,
we
yes,
can
yes.
correlate with the anatomy.
Yes, 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 yes. Actually, जो रास्ते में आ रहा है हो रहा है.
Yes. So in pterygoid exposure, it's like you go to the completely to the dura by seeing all these things. So I mean approaches. It will take it to the. You can go till gesturing ganglia.
Dr. Datta, one thing I want to tell
Yes, sir.
that if somebody is planning to do extended exposure,
Yes, sir.
so he should do bilateral superior trabeculotomy, open posterior spinal cell on both sides.
Yes, that is.
Posterior spinal cell by doing a bilateral superior trabeculotomy. दोनों तरफ. That will be good exposure.
Yeah. So what you can see here right now, this is the tuberculum.
You see now I am seeing the LOCR of opposite side.
Yes, sir.
Okay.
Yes.
So if you want to do it extended procedure, so if you are limited with this symptom which is present at 2 o'clock, so your exposure will not be complete.
Yes.
Did you realize? So that's why we focus much more time on exposure. Exposure time 90%, temporal time is 10%.
Yeah. So what like we were discussing yesterday, exposure for assessing the pituitary area compared to the approaching other area is totally different. And what is removing like all this ethmoidal, posterior ethmoidal cells, right? You can, once they are removed the mucosa, it looks like honeycomb appearance, right?
So this is known as cavity in half approach basically. Cavity means sphenoid sinus, half means posterior ethmoidal cell both sides.
Yes.
You see,
yes.
this should be the exposure adequately.
Yeah, yeah.
Even this, if I go and I will show you. You see, this is the inferior turbinate.
Yes.
This is the coena.
Yeah.
This I am now on the left side. This is the
Okay.
middle turbinate.
Okay.
If you go behind the middle turbinate, you see this is the superior turbinate. It is still tight.
Yeah.
Okay, Dr. Datta.
Yes, sir. Yes.
This is the superior turbinate.
Yes, sir.
So you go, just put your dissector lateral to the superior turbinate. You will enter in the posterior ethmoidal cell. I told yesterday.
Yes, sir. You are nicely shown yesterday.
So once you remove this,
Yeah, so actually you should not worry too much about the superior
turbinate,
turbinate.
yes, yes.
It's just a bunch of air cells. So normal pituitary, we try to preserve maximum thing. For other approaches, if it is necessary, we have to do it.
so now you see the exposure.
Yeah, very nicely.
So this amount of exposure should be there.
Yeah.
If you are doing the,
Yeah, meanwhile you can just clear some
yes.
blood and so it will look nice. Or you can give a wash also. Sir. So like this.
if your exposure is good,
Yeah.
one of your assistant can remove the tumor. Let me tell you.
Yes, sir.
You see now the carotid, you can see the optic, you
Yes,
can see
sir.
the pneumatization of the enteric blood process.
Yes, sir.
Let me show you LOCR also. This is LOCR. This is LOCR. This is enteric blood process. This is optic.
Yes, sir.
Vital. I do vital.
So LOCR is correspond to the optic strut. One of the attachment of anterior clinoid process. It can be pneumatized like this. Yeah, it's looking nice now.
Okay.
Yes.
So I hope this interior of the sphenoid sinus anatomy is clear now. Huh?
Yes. So if you see him, what he has done, like initial
You
when
see,
there
I am keeping still some amount of over intact for keeping me midline.
yes, sir.
and we keep on referencing it.
Yes, sir.
Although we can see this is also in midline, now midline, but still you have to keep some amount of normal anatomy.
Yeah, easy reference anatomy.
So I am now drilling tuberculum.
Yeah, so the earlier like he was removing with the punches
no,
when it is the
here,
free bone, but
here.
when you are working on this
here.
area, never use the upcut, never use the direct punch. You should excel it with like a pen brush type drilling, as you can see here.
That was the time in all cases of craniopharyngioma, we open the tuberculum, some
Yes.
amount of plenum, MOCR,
Yes, sir.
so that it enhance the exposure like anything. Your maneuverable dissection becomes very good.
Yes, sir.
It takes some time, and believe me, if you follow the strategy of taking break, which most neurosurgeons don't take, your result will improve like anything.
Yeah, so we know now, sir, like after how many hours we can call you. Another important point, see, you have to be very careful.
I am
at
drilling
this
plenum
area.
also, some part of plenum.
Yes, sir. Very careful at this area because your drill, if it is not gentle,
I keep on manipulating
small
like this.
movement can
Pandal.
cause injury to the optic nerve or carotid here.
Huh?
We have shown yesterday some of patient like when we are using upcut, how it comes into the
भाई,
punches, right?
But my आगे होगा, चला गया
So
वो,
general
आगे
idea,
होगा.
you excel it and uplift with that dissector. So I mean, when you are watching actually endoscopic surgery, you have to understand it's not about destination or identification of a landmark. It's about how somebody is moving with his instrument. That is one of the most important thing. Then you can do anything possible.
वीडियो बना बनना चाहिए ना, हैं? इधर देख बात करो, वीडियो बड़ी बढ़िया बनना चाहिए ना, इसे देख करके.
And he very nicely like endoscopy is being assisted.
Yeah,
Like if you can see, it is not sword fighting, right? It is there and they are doing. It is not necessary that you should always have endoscopic image in the center. Okay? You can either put it on the corner and you can have one area in the other half so that your instrument doesn't fight it with each other. It depends upon the case. In this case, like it is just showing, like in anterior, as I said, that case that I have shown, we have marked like till where it is, and then we can open it up. No, if you
Dr.
want,
Gupta,
yes, sir.
In our practice and our place,
Yes.
after doing the exposure, we mark with the drill
Yeah.
which much part of bone is to be removed like this.
Yes, sir.
So I keep on drill and take out the bone piece in toto. And the same piece can be taken as a for reconstruction.
Yeah, camera reconstruction. So for the transplanum approach, as like textbook size, so is it from anterior part of sella or tuberculum to the posterior ethmoidal artery?
Yes, yes. Depending on where the tumor is.
Yeah. So textbook wise, we call it this one, but extension of tumor it depends.
Like you see,
Yeah.
this area has become now thin. Okay, it's moving.
Yes.
The moment it's moving, they start the drill, use upcut 1 mm.
Yes. So if you can see here, this is optic. This is another optic nerve. You can see this tuberculum, and you can see this area. This is the posterior ethmoidal arteries here, right? You can see this coming here. So this area generally, like this is called tuberculum transplanum approach. And if you see that this dura come there and come here, like so, whenever you use the upcut, it is like you will definitely tear the parenchyma.
कहीं bleed होती है.
Sir, there was a question.
Yes, yes.
So, do you routinely remove the bone of optic canal?
No, depend on the situation. If you are doing a fracture, you remove the fracture segment. If you are doing optic nerve decomposition, you have to remove it.
Yeah.
Otherwise, if you are doing meningioma, which usually we have stopped doing by nose,
Yeah.
so you have to remove it on that side.
Yes.
If you are doing for craniopharyngioma, only up to the MOCR we remove it.
Yes. So the ideology behind removal of MOCR is that it take care of those area like diaphragm attachment, which gives the access. But like those people who do the meningioma and which has going into the optic canal, people go ahead with the optic canal decompression, removal of those meningioma. But itself is debatable how much endoscopic should be utilized for the meningioma.
Okay. So you see this side also carotid got opened.
Sir, why you have stopped using for the meningioma? Good question.
Yeah. I found that if you do meningioma by supraorbital keyhole approach or mini-tunnel, this much peak exposure, no chance of CSF leak.
Yes.
So that's why everywhere in my center they have stopped doing it.
Yes,
Only
but-
in selected cases we do it, otherwise no.
Yeah, but I mean, like again, you can tailor it to the depending on the case. If it is has the medial and inferior optic canal extension, then you can definitely.
Yes,
you
that's
can
why I am
follow.
telling you that in very selected cases we do it,
Selected
otherwise you
cases.
don't do it.
There is a role. I mean, it's not absolute no for everything.
Yes, that's right. You have to choose the select patient.
Yeah, but in the, whenever we are talking regarding general audience, like we are telling you what is standard rule or what is the practice.
For anterior canal fossa meningioma, now standard, we believe that's transcranial. It may be even olfactory group meningioma. I used to remove by nose by transcription approach.
Yeah.
I have done about 12-13 cases, but now I have stopped doing it. We do it by simple supraorbital keyhole approach or mini-tunnel, one
Yes.
side.
Yes. Yes.
Earlier we used to do bifrontal bicoronal approach. Okay.
Yeah.
Interhemispheric.
So you can see here on the left side cavernous.
So you
sinus.
see
You can
both
see-
side carotid artery.
Yeah, this
This
side
is-
that periosteal dura is removed, so you can see the is going up, going
Yeah,
to
yes,
the post
yes,
genu, right? Turn, coming anteriorly this siphon. You can see the pituitary tumor goes inside it, and then forming this anterior genu ring at this side, right? This is the proximal dural ring.
This
This is
proximal dural
distal
ring.
dural ring, and you can see this pituitary ligaments. You can explain it about pituitary ligament when you attach.
Yes. Let me show you. So this is the gland.
Yes,
This is some ligaments.
yes, sir.
This is the dura.
Yes.
This is the, I think, proximal dural ring.
Yes.
Okay.
Yes.
You have to look further here.
Inferior.
If you have a physical artery, which is
Yeah,
very important, sometimes it's large, sometimes very small.
We can, I think in the middle of it, we can see it.
Yes.
ये बताता हूँ बाहर. That is the inferior hypophyseal.
I think, yeah, we can do it. I think this is the inferior
Inferior
artery.
hypophyseal artery.
This is large, okay? Are you able to see?
Coming in. Yeah, we can see it.
So you have to coagulate it to mobilize the pituitary gland.
Yeah.
In some situations,
What you are separating is the diaphragma now, right? Yeah, you are going to hold it.
this
Yeah.
ligament, ये नीचे लगे ये.
Yes.
This
So,
is the inferior pituitary artery.
yes.
This is posterior gland process.
Yeah.
In some situation of carcinoma, what happens? You have to, the posterior gland process also involved.
Yes.
And the tumor involves not only the clivus, goes lateral also. You have to do transpterygoid, transclaval, everything. Transspinal all approaches. So in that situation, you have to remove the posterior gland process. So what you can do like do externally, lift the pituitary gland up. You can remove from here also. Otherwise, or you can open the cavernous sinus here, retain the pituitary, do transposition, and remove the posterior gland process like this.
Yes.
Okay.
Yes. Yes.
This is the posterior gland process.
Whenever you put some instrument and try to just pull it, like just
Yes,
imagine
yes.
this has to be done under vision.
Under vision.
Yeah,
With
if you
great
just
care.
pull it, can you imagine it just get teared off from this IC and it will cause lot of bleeding. So there is nothing blind procedure in this, you under vision.
दीपक अंदर जाइए. So this is stalk basically.
Yeah, we can see the stalk.
Okay. If you open this, we sometimes require for doing tumors going into the. This is basically distal dural ring.
Yeah, this is the distal dural ring and this is proximal dural ring. You can see here
ये ऊपर
this
वाली.
structure.
ये diaphragm का. हाँ. Okay. This is distal dural. You open it, and then you enter into the.
How do you open the dura? मतलब like ऐसे ही सर मिड लाइन में करके उसको कोएलेट करो तो खुल जाती है.
This is the. You see, this is the aptitor
Yes.
going like this
Yes.
and going in the optic. Yes, you see. This optic canal
Yes, sir.
going in the orbit.
Yes.
Are you able to see?
Yeah, we can see. Appreciate. Very nicely demonstrated, sir.
Okay. So optic nerve continuing.
Yeah.
So this, if you are at all apathetic meningioma, you can tumor sometimes goes here.
Yeah.
So you just make a slit take out the tumor.
Yeah,
Here.
so how you repair? I mean, any consideration like when you opened like this and you open the dural slit, what is your particular thing, like how you close it? How you put a flat? You put a fascia?
Let me tell you what I do.
Huh.
What we do after doing hemostasis, everything,
Yes.
we take a large facial flap.
Yeah.
We first measure it. How do we measure it? How much is the defect? Take a cotton,
patty, yeah.
a cotton patty, put it there, and in relation to cotton patty, you know how much is the defect.
Yes.
The fascia should be more than 3 times, because usually it contracts.
Yes.
1/3 gets contract, even then 1/3 part is able to cover the whole defect.
Yes.
If you take about exact same amount or little bit larger, it is going to fail.
Yes.
So 3 times repair, just put over the, inside the pack with the gel foam,
Yes.
and I believe the gel foam is like a Duragen, which is very expensive. Then put fascia over it.
Yes.
We do not put fat inside,
Yes.
because if you pack with fat, what happens in the dural defect, some amount of fat will prolapse outside.
Yes.
And if it prolapse outside, it will impair your attachment of fascia with the dura and bone.
Okay, sir.
You can understand.
Yes.
So that's to avoid that, we don't put fat inside. Rather, we first put only fascia, then over some amount of bone, then some fat, and then other flap.
You put or inlay fascia.
Only.
Yeah.
We believe that if you put inlay fascia, and even if manipulate like anything, still your inlay fascia will not contact with the all part of dural edges.
Yes. Another, yeah.
We don't use it.
And the packing or the things you are doing, it is totally different than what you do for the sella or normal pituitary, because you just imagine there is hardly any space. If you just put fat and pack it like normal, it will cause a deficits, vision loss.
Okay, so I think this area is clear.
Yeah.
You can do subfrontal tumor here from here. You can do chiasm. See, if you are doing craniopharyngioma, let me tell you,
Yes.
craniopharyngioma is 3 types basically. You know, 4 types. Kasam has described.
Yes.
The moment you open it here, you will see the tumor covered with arachnoid.
Yes.
Yeah, just dissect the arachnoid. You will see the superior hypophyseal artery. Somewhere. Yeah.
So we can see these
Yeah.
branches.
Okay.
Yes.
So dissect the superior hypophyseal artery and make lateral. You will see the tumor.
Yes.
And then what happens? That many a time what happens? The tumor shifts the stalk one side
Yes.
and bulge into this supracellular space.
Yes.
So they dissect all around and then go inside. The tumor will be bulging somewhere like this. Okay.
Yes.
So dissect all around, decompress it, and then take it out.
Okay.
So, yeah.
Yeah, I think
you
we
go-
can see the
if you go-
pecom posteriorly.
No, not. A very small part. Very small part. Here the posterior clinoid process is very large. If you go inside, you will see mammillary body,
Yes, mammillary body, pecom,
pecom, and all.
yeah, and basilar posterior.
You lift the pituitary gland. We try to keep the liquid membrane intact in case of craniopharyngioma. This avoids any injury to the basilar artery and vessels.
Yes. So, I mean, if it is like chordoma and this one, if it is involved, this much like you have to actually lift and remove it.
If it is tumor is involved. So this is basilar artery.
Yes.
This is mammillary body.
Yes. Basilar artery, PCA.
Mammillary body
SCA.
on the section. Yeah, basilar. Basilar, PCA, third nerve. You can see the third nerve also, both sides.
Yes.
PCA, SCA, okay?
Yes, yes.
Yeah.
This is third now. So, I mean, once we
Some-
open,
many
we
time-
can
many
trace
time
it
tumor
from here
projects
to
from
the
here.
sinus and to the
You can see
orbit.
the bifurcation also.
Yeah.
I see bifurcation. A1 is going.
Yes, yes.
You see, endoscope is very addicting. Eh?
So idea is like you can see this how these structures are like this
Yes,
is
yes.
covered with the face this one periost.
Now I'll show you the
But here
lateral
you
wall
will make it out.
cover the sinus here.
So your movements when you are removing pituitary is like you have to identify where tumor
But
is.
what
Yes.
I am telling you,
Yes,
that if you are seeing the carotid here
yes,
and you put in Doppler, there is no use.
Yes.
Because you are only seeing with carotid.
Yes.
So use of Doppler when you are not able to see pituitary, particularly in case when the tumor is encasing carotid artery.
Yes.
And you try to find out where the carotid artery is.
Yes.
So that is the use of using carotid Doppler. Okay, correct use.
Yeah. Especially while making incision,
Yeah.
going for the cavernous sinus.
So you see, this is the sixth nerve,
Yes.
lateral to the ICA.
Yeah.
Okay.
Yes. Yes. We can see this sympathetic trunk going up.
Yeah. Going down also.
Yeah. So this is sympathetic trunk, sixth nerve, just lateral to ICA going up. We will show. I mean, this is. We'll more.
This
we'll
is the
clarify.
proximal dural ring.
I'm just preparing you for like what will.
Okay, this is the proximal dural ring.
Yes.
Okay, ये छोड़िए, ये आगे वाला ये. So this is third nerve. और here was V2. पकड़िए.
Yeah. You can remove this periosteal layer of duracell so that it becomes clear.
I will continue the V2 to the glycerin ganglia.
Yes. See now, as you have removed this pterygoid bone, you could access this area and work on it. Otherwise, it like you it was just not accessible. So now everything will look easy because there is no hindrance.
So this was V2.
Yes, sir. We can see this maxillary artery. This V2, that pool is going into the cavernous sinus, inferior
You see,
part.
this is the remnant of the foramen rotundum.
Yes.
Okay.
Yes.
So this is the remnant of the foramen. This is foramen rotundum. Let me remove this bone also. In live situation, it's very easy because the tumor itself gives the space. It's not so difficult, and particularly the tumor, most of the time, chondrosarcoma tumor is dural. So this becomes the ideal approach. No chance of CSF leak, or very little chance of CSF leak, if the tumor is intradural, some part. So I am going to cut this
Yeah.
periosteal.
You can use the scissor if it.
This is lingular bone, lingular process. This mobilize your carotid, okay?
Yes.
You see, this is the V2?
Yes.
Huh?
Yes, we can see the fibers of
So
the
this is V2, and these are the, this is V1.
Yes, sir.
And if you go behind, you will see V3 also. If you remove this bone,
Yeah, at this moment, like you can show the V1, V2 cavernous, and so then last we can work on this V3 and petrous areas.
Pandal. हाँ फैट वेट लगा दो फैट पेशी है कैरोटिड से भी कवर्ड नहीं नाक से हवा जाएगी ना अंदर तो कैरोटिड में रप्चर पैंडल Basically, this is the area of petrous apex. You should try to attempt tumor which are bulging in the paranasal sinus in initial cases. Extradural tumors. Once you are conversant with the anatomy, you can try for schwannoma, which are intradural tumors. Okay?
Yes, sir. Advanced surgery.
Advanced surgery, yes. Actually, cadaveric dissection makes a concept and makes learning curve easy. So I think this will be the last part. After that, participants can do.
Sir, yeah, we're with you. Just we had power cut, so we lost last communication. So can you repeat again?
Yes, I am dealing the some more part of bone. Basically, this is a part of bone between the V3 and the Vidian. This is known as mandibular strut.
Can you show the relation of ICA at this level?
This is ICA,
Yes.
and this is probably attachment of Vidian. Okay, here. You see?
Okay.
So ICA has gone here. This is the foramen lacerum.
Okay.
If you open it here, you see, I am opening the dura. Okay. You see the dura has been opened. Here, this is the fibrous band.
Yes.
And here the ICA is going in the pittus part. So you can cut this band.
Yeah.
Kachi कहाँ गई भैया? ये है.
Is there any name of this fascia, sir?
This is not fibrofatty tissue in the lower part of the foramen lacerum. You see, I cut it without any problem.
Yes.
Huh? Because ICA is going behind. It's not below it.
Yes, sir.
So, yeah, this part of bone, if you remove, we'll see to the V3, I think.
Yes.
You see, this bone is affecting my view. My
Yes.
section,
Yes.
this bone.
Yes.
Okay.
Yes.
So what happens? This is very important during extended procedure. If there is any obstruction, you have to remove this bone more. Okay. So
Yes.
that your access instrument management will be easy.
Yes.
If you have any problem, then with your access of the instrument, remove your obstruction. नहीं ठीक है. Dr. Datta, I hope you understood the importance
Yeah.
of opening posterior for yourself.
Yeah, very nicely, sir.
भैया. So
Posterior.
make it a habit.
And
In all cases where tumor is going up to the cavernous sinus, cut the superior turbinate, open the posterior thyroid cell, it will enhance your exposure significantly and work become more easy. Bhaiya.
yes. Dr. Anand also have taken selfie with the ground lamella, sir.
Sorry?
Like your explanation of ground lamella was very nice.
It took 6 months for me to learn what is ground lamella. Everybody is speaking ground lamella, basal lamella. There are 2 more lamella, you know. One is medial lamella, one is lateral lamella. So, you know the first part of middle turbinate, which attaches with the cribriform plate, vertical attachment, sagittal plane.
Yes.
So, the part of cribriform plate medial to the attachment of the superior turbinate is known as medial lamella.
Okay.
Medial lamella leak. The part of the middle turbinate, part of the cribriform plate lateral to the middle turbinate is known as lateral lamella.
Yeah.
The importance of this is this: when case of spontaneous cease of rhinorrhea, you have to identify in the scan where is the site of leak. Is it medial lamella or lateral lamella? If it is medial lamella, you have to lateralize the middle turbinate to find out the site defect. If it is lateral lamella, you have to medialize the middle turbinate. Okay.
Yes.
So this understanding is important. You have to learn some ENT stuff also.
No, we have to learn all the NT stuff, sir.
Not all. I'm still learning. जो आ गया चलिए करते हैं. देखिए अब थोड़ा हमारा सेक्शन बढ़िया जाने लगा इधर ना. अगर पहले सेक्शन था, अभी थोड़ा बोन हम और निकाल देंगे.
Yeah, yes.
You know, endoscopy is a minimum, provide direct access.
Yeah. So another same simple point what we were discussing is like to operate here, your triangulation should be good so that your instrument can at least reach it. If
And you
it
know,
is-
I am using only 0 degree.
Yes. So how much bone to be removed? It to be tailored according
Yeah,
to the
actually,
case.
depending on need, just take up anatomy, we are showing it.
Yes.
Otherwise, depending on need, you have to study on radiology.
Yes.
Do not remove unnecessary bone, don't see the structure which are not required.
Yes. Even in the cadavers.
Yeah, ना कड़वा तो आपको देखना है.
अरे नहीं इनके लिए बोलो.
हाँ, इनके लिए, ठीक है. भैया पानी डालो.
You are near Ichian tube.
You see, now I have reached to middle cranial fossa. This is middle cranial fossa, okay?
Yes.
Do you have the middle cranial fossa? So you have some region, you can remove some more bone here.
Yeah. So the lateral part is middle cranial fossa.
Yes.
Yeah. So the
You can understand, you have reached almost lateral part of the this cavernous sinus.
yeah.
If you open more area here,
Yeah.
the tumor will be here. Suppose the tumor is lateral to the cavernous sinus, ICA.
Yes.
This exposure is enough. You can open it.
Yes.
You know?
Yes. So, for your understanding, I mean, like it starts from here, cavernous sinus, lateral part of cavernous sinus, anteriorly it will continue as a superior orbital fissure.
Yes.
Yeah, and inferiorly, if you see that V2 and V3, then that form a base of middle cranial fossa. If you go medially, then there will be like Jesserian ganglia and bony area, Peter's apex. So,
भाई आप बहुत तेज हो. Maxillary. Somebody is asking what is maxillary strut. Basically, maxillary strut is the piece of bone between the superior fissure and the V2. Mandibular strut is piece of bone between the median and foramen lacerum and the this V3. And optic strut between the superior fissure and optic canal. There are 3 struts. This fancy name. If you want somebody you can ask this question. Pani bhaiya. Our anti-clinic knows more.
So is that the sixth nerve?
Sixth
which
nerve is
is-
here. Sixth nerve is here. This is the sixth nerve.
And what is that following the sixth nerve posteriorly, sir?
This is V2.
नहीं एक जो vessel है कि it's an
ये
हाँ
ये sympathetic branches होंगी.
sympathetic branches, above that will be sixth nerve. Yes. Perfect.
V3 कहाँ गया? ये this is Dr. Datta.
Yes, sir. We
This
can.
is the V3.
Yes.
Okay.
Yes.
Section के ठीक पीछे V3 है. इधर V2 है ऊपर.
V2 can you trace from posterior to anterior?
V2 here आगे जा रहा है.
Endoscopic.
V3 इधर जा रहा है.
हाँ.
ये आपका ये V1 वगैरह होगा सुपीरियर फिशर में.
Yes, sir.
देखिए V1 यहाँ से यहाँ जा रहा है. 6 नंबर ये हो गया है.
Yes, sir.
उसके नीचे V1
Yes.
एंड ऑल. हाँ.
Yeah.
V2 ये है जा रहा है ये. ओके.
Yes, sir.
V3 ये है नीचे उसके एक पोर्शन
Yes.
गया हुआ है. हाँ.
हाँ, ये V3,
एक पकड़
ये
ऐसे
V2.
पकड़ो, ऐसे पकड़ो भैया.
ये V1. So these branches हो गए.
This is V3 in foramen oval.
Yes, sir.
This is V2.
Yes,
This
sir.
is V1.
Yes, sir.
This is
Sixth
nerve.
nerve.
This is ICA.
Sympathetic. Yeah. Can you
Okay.
visualize the ICA? Yeah.
एक मिनट
अरे yes, now these are two more now. Yes,
then you see third nerve also.
yes, so this is third,
Okay,
this is third, this is fourth.
this is third nerve. Huh?
Yes, yes, we can trace it to the post. Oh,
This is posterior genu. Hmm.
meningo hypophyseal trunk देखेगा सर?
Inferior lateral trunk किधर होगा? meningeal में पीछे होगा.
inferior hypophyseal trunk will be there laterally, this one.
Inferior hypophyseal somewhere कभी
inferior
मिलता
lateral.
है, मोटा होता है, नहीं तो rudimentary. उस तरफ दिखा था पीछे,
दिखेगा सर, यहाँ पे कुछ नहीं. हाँ,
लेफ्ट साइड दिखा था.
क्या दिखाना था? You can see the carotid calcifications, atherosclerosis, so be careful. What you are trying to see, sir? That is that
Inferior hypophyseal.
yeah, that is inferior hypophyseal on that side. Yeah. Can you medialize the ICA, sir, and we can see the other structures? So yeah, so your proximal dural ligament is still intact, right?
Yeah, proximal is here.
Yes.
Distal is here.
Yes.
Now proximal I have cut.
Okay.
Proximal, this is distal ring.
Distal dural ligament. Yes.
Okay.
Okay.
If sometimes there is frontal exposure, somebody is having a subfrontal pituitary, okay. So if you cut the distal dural ring somewhere, then you enter inside.
Yeah, so I mean, very nice demonstration, sir. Like, we appreciate it. I mean, it's like 12:30, right?
Okay, Doctor.
Yeah, yeah.
So last,
Yes, sir.
if you want to see the clavicle, then drill this area. I already showed these things.
Yes, sir.
It's very thick bone.
Yes, sir.
Sometimes it's pneumatized very well.
Yes, sir.
So from up to down, you have to expose it. You can go up to the front magnum.
Yes, sir.
Okay.
Yes,
You have to remove this part. If you are, you have to remove this piece of bone. Okay.
Yes, yes, sir.
And you have to cut and this soft tissue also.
Mm-hmm.
Okay.
Yes, sir.
And make a midline incision, like we did in some cases, anterior decompression for CV junction anomaly, where the odontoid is going very high up.
Yes, sir.
Okay.
Yes,
and
sir.
keep on reflecting this pharyngobasal fascia, this mucosa,
Yes, sir.
and remove this part of bone. You will go see the clavicle dura.
Yes, sir.
For dead midline meningiomas, you can do this procedure.
Yeah.
I did one case where the spread surface was completely non-pneumatized.
Yes.
One day took the only bony work. Next day I operated, removed the tumor.
Yeah. So one more point, like when going for the clival, if at all it is not a clival bony lesion, I mean, it requires a lot of bone drilling. It bleeds a lot. But otherwise, if at all you are working around the ICA, it's better always to drill a bone on the medial side of ICA so that it becomes little bit of, I mean, you can mobilize it. Otherwise, if it is stuck, then it can get damaged.
ठीक है. प्राइमरी
Yeah.
पिट्यूटरी से लगते जाता है. डिस्टल जो है उधर पल्सिफर लिगामेंट से लगते जाता है. ये ठीक है. Okay, Dr. Datta.
Anything else you want to show? Yeah, yeah. Thank you very much, sir.
Thanks everybody.
Yeah, yeah. Very nice demonstration. You can see the loud applause for you.
Thank you, Dr. Datta,
Yeah.
for giving me this opportunity.
Sir,
Thank
it's
Deepak.
all yours.
Thank you for demonstrating the bloodless surgery, sir.
We tried to simplify it by pointing all the things. Yeah, please.
If somebody has any question,
Yeah, I'm asking them. नहीं तुम पूछो.
Hello. Sir, can you please show the entry at the lamina terminalis to enter into third ventricle?
lamina terminalis.
Yeah, yeah. That intraventricular portion that he wants.
Okay.
I mean, just above the IC and then.
Dissector. पतला वाला dissector यही है, ये है.
In craniopharyngioma anyway, like tumor
Yeah,
goes
yeah.
inside.
Yes, I'm showing you. बत्ती जला भैया. You see, if one see lamina terminalis,
वो IC कभी भी tumor रहेगा. उसके लिए नहीं बात.
then you have to go above this. Yeah, suprachiasmatic. You see, this is acom.
कौन?
जरा दीपक पकड़ लोगे क्या?
नहीं. ट्रांसमेजुलिटी में एक लोगों ने जैसे वो आगे फ्लेक्सिबल थे तो क्या ज़्यादा ही करो।
You see, this is a complex. Under.
Yes.
And here you will see lamina terminalis.
Yes, yes.
I have opened the lamina.
Yeah. Now you want Thalamus? Yes, we can see it. Yeah.
Okay.
Yeah.
Under. Okay, this lamina is open now. You can see the third ventricle interior.
Yes.
नीचे.
Yes.
Okay, interthalamic adhesion.
Yes.
थोड़ा ऊपर दिखाओ, ऊपर थोड़ा look like. हाँ ये. Collateral plexus, foramen Monroe. Okay.
Yes, sir.
In fact, chemical tuber syndrome ये है. Sometime in cadaveric pharyngioma you have to do tuber syndrome approach.
Mm-hmm.
So in that situation, the stack is pushed to one side. Okay.
Yes.
This is area tuber synarium. The tumor comes in the supracell area via this.
Yes.
Okay. So through this we open and this go inside the ventricle and take out the tumor.
Yes, you can see the mammillary body here.
You see, this is the ventricle has got opened now.
Yes.
रख दे पंडित जी. Okay.
Yes.
Are you clear?
Perfect. Very nice.
Okay. Thank you.
Yes. Thank you very much.
So echoaneurysm can also be clipped.
I think
People have done.
there is no contraindication.
Yeah, people has done endoscopic.
People have done it, and after some time, some people may accept it, but as of now, people don't accept it.
Yeah. Even even basilar and all thing people have done that, published.
और ट्यूमर किधर से आ रहा है, जिधर से ट्यूमर नीचे निकल रहा है उसी तरफ जाओगे आप, ऊपर से नीचे से.
So once again, thank you very much, sir. See you for the lunch upstairs. So again, story goes same line. We go down after lunch. The same cadavers that were yesterday, 2 teams. Today require more coordination, right? I mean, if you help each other to reach one spot and one transfer, but also it's more than enough because ultimately understanding anatomy is important. And again, it will be difficult. Anytime if you have any problems, if you don't understand, if you just go on cutting and drilling, then you damage the structure, then it's very difficult to tell you how to imagine those things, right? So go slow in that area. If you just inside go first, go into this tuberculum, like you already opened the stela, you know optic carotid, you open the things in anterior cranial fossa, you take the bone off from the carotid, so that acts as a reference point to understand that how you are doing, and then go for the transperigoid, and then go, right? For another reference, what you can again do, you can do a medial clival that clivus drilling, so that at least again that acts like where ultimately your median will be. Go slow. Any problems? 2 people who are hands-on, they have rights, and they are only one who are doing it. Rest of the people will be assisting, not assisting or watching you. They